Well, hi everyone, and thank you all for joining us for this webinar, which is part of a series of presentations funded by the Australian Government Department of Health from the Comorbidity Project on applying evidence in practice. My name's Catherine Mills, and I'm the Director of Early Intervention and Treatment Research at the Matilda Centre for Research in Mental Health and Substance Use at the University of Sydney. And these are normally hosted by Dr. Christina Morell, but unfortunately is unable to be here today. So along with Erin Madden, I have the pleasure of facilitating this webinar, which will be presented by Professor Brin Grenyer. But firstly, I'd just like to acknowledge and pay my respects to the traditional owners of the lands on which we're meeting, and recognise that we're meeting on all other lands across Australia today as well. The traditional owners of the lands that I'm currently on are the Gadigal people of the Eora Nation, but I'd also like to pay my respects to the other traditional owners of the lands from the lands upon which you are here today as well. And also like to recognise and acknowledge the many people with lived experience of mental illness and substance use and their families and carers, many of whom have generously contributed to the development of our comorbidity guidelines and other resources. So if you've been to one of our webinars before, you would have heard this information already, but I will just quickly mention that you're all in listen only mode, which means that we can't see or hear you. If you have any questions for Brin, please use the Q&A button on your screen at any time during the presentation today, and we will have some time for questions at the end. If you have any comments or anything other than questions for our presenter, please use the chat function, and this will just help Erin and I to identify any questions that you have for Brin, as opposed to separating those out from general comments. And if you have any technical issues during the webinar today, you can contact Zoom support. You can also access the recording of this webinar later on for download, as well as the PDF handouts from the slides today, which will be available at the web link on your screen, and we'll also send a follow-up email to all of you who've registered to follow up on that. And you can also access all our previous webinars in the webinar library using that link provided. So today's webinar is focused on personality disorders and alcohol and other drug use, and this was a topic organised in response to some of the feedback that our viewers have put to us. And so thank you for coming along, but also for engaging with us in what kind of areas of interest that you'd like to see these webinars conducted on. And please do continue to give us suggestions for what you'd like to see as part of this series, and we'll hopefully be able to arrange those. But now it's my very great pleasure to introduce our presenter for today. Professor Brin Grenyer is Senior Professor of Clinical Psychology at the University of Wollongong and Director of Project AIR Strategy for Personality Disorders. Many of you would be familiar with Project AIR, which aims to support compassionate, evidence-based treatment and recovery for people with personality disorder and related conditions. Project AIR generates scientific research discoveries, also inspires through education and training, and consults across many services, including New South Wales Ministry of Health, the Department of Education, but also with other states and territories and internationally. Brin is listed in the top 1% of world experts in borderline personality disorder, and is president-elect of the International Society for the Study of Personality Disorders. So we're very, very fortunate to have him presenting here today. So I will pass over to you, Brin.
Thank you so much, Catherine, and welcome everyone. And it's so lovely to see so many people from all around the world, across Australia and also locally. I'm also just going to share my screen. I've got some slides which you'll be able to get at the end of this presentation. But just to start, really, what you need to know. I've particularly said this because this is a big topic and we've only got an hour to think about it. So I very much are going to talk about what I see as some of the really key principles. These are the three key learning outcomes, and I'm going to go through each of the three. So there's only 3 points that we have to worry about. One is identification. what skills you need to use to help, and also how do you manage yourself in terms of the interpersonal challenges of this kind of work. So they're the three things that we're going to focus on today. I also acknowledge the traditional owners. I'm on Dharawal land at the moment, and pay my respects to traditional custodians and cultural knowledge holders. Also to those with lived experience, to my colleagues in Project AIR, and also to the Illawarra Health and Medical Research Institute and University of Wollongong for supporting some of this work. Everything that you want to know about personality disorders and the work that we're doing can be found at projectairstrategy.org. And it is a huge website. We've got a lot of videos, we've got e-learning, we've got fact sheets, we've got treatment manuals, and I'll refer to some of those. So that's your go-to place to follow up from this webinar. So firstly, identification. And what are the challenges in terms of an alcohol and drug environment? Well, we know that when we think about some of the difficulties in substance use disorders, they can be broadly classified into two major areas: personal factors and interpersonal factors. The personal factors, of course, turn around the challenges that people have in terms of managing the feelings of cravings, the increased tolerance, their withdrawal symptoms if they try to stop, and just the way the mind continuously thinks about using substances. And the interpersonal factors, of course, are all of the conflicts and problems that happen: failing responsibilities, having interpersonal conflicts, losing all of your friends, or only having friends that also use substances. And, you know, the real kind of interpersonal challenges around that. And of course, they are all of the kinds of challenges that we also see in personality disorders, and they really overlap. And there is a lot of co-occurring challenges in both of those areas around personal and interpersonal. We know, of course, that actually the criteria themselves overlap. So the impulsivity criteria overlaps between substance use and personality disorders, particularly borderline. We also know that the emotional, affective, and interpersonal problems resemble often personality disorder kind of features. And there's really lots of kind of questions about the chicken and the egg, which came first, the personality dysfunction or the substance use, or is it co-occurring? And there's really bi-directional models there. Here's a bit of a case study, and we'll refer to this a number of times throughout the webinar. So Susie, 25, is recovering from entrenched methamphetamine and cannabis use, and has been working with a vocational rehabilitation counsellor, Tony, for 2 weeks to prepare for job retraining. One day, just after Tony gets everything set up for Susie to begin her training, she storms out of the office screaming at him, "You're just trying to get rid of me. You don't understand me at all. I hate you." Later, Tony calls to suggest that maybe Susie would prefer to work with another counsellor, which enrages her even more and says, "Please don't drop me, Tony, I need you." So if we just think about this, when we think about personality disorder criteria, and I'm going to start by talking about borderline, even though antisocial, narcissistic, obsessive compulsive, and a whole lot of others are relevant. But we know the most about borderline, and often it's the emotional dysregulation that comes up as one of the big key challenges. But also in many ways, borderline is kind of like the common cold of personality disorders. It's the one that's most prevalent, and if the features of BPD actually go across all of the other personality disorders. When we think about those, we have interpersonal criteria and personal criteria, and these really form the signature of what it means to have this particular personality disorder. And then we have a bunch of comorbid criteria. It's important to understand, though, that the interpersonal and personal criteria are kind of like the ones you really need to think about most when you're trying to identify, is this person got a personality disorder or not? In terms of the interpersonal, there's the frantic efforts to avoid real or imagined abandonment. And that's what happened when Tony said to Susie, well, maybe you need a different counselor. Suddenly all of her attachment anxieties came up. And also there can be a real struggle around getting the right distance interpersonally. So either getting too close to the person and idealizing and then putting all your hope in them, or being so distrustful that you push people away and devalue them and think that nobody can help you. But underlying a lot of that, and I think this is really one of the core issues, is a real sense of I don't really know who I am or where I want to go in life. So a real identity disturbance and a feelings of emptiness inside. They may well be some of the core triggers that actually fuel substance dependence in the first place. That's just a question I'll leave for you to think about. But in terms of the other criteria, we have comorbid issues. So we have impulsivity, suicidal and self-harm, big emotions that can go up, irritability, anger, and also sometimes revolving to paranoid ideation or dissociation. Of course, you see these in substance dependence as well, especially when the person's in withdrawal or really struggling. Here's the data on the co-occurrence. In terms of current rates of borderline personality disorder in substance dependence, it's about a half. And it varies, and there's a little bit of a variation there depending on the kind of substance. So alcohol up to 30%, cocaine 39%, opioid 51%. It also probably varies a little bit depending on the setting and the kind of personality dysfunction. These are a little low, and when you talk to people working in the field, they say, oh, well, it's 70% in ours. I think it's relevant to think about the kind of setting that you're in, and the more acute and the more severe, the higher the prevalence. This is the reverse. How many people with personality disorders actually have substance dependence, and it's high, 72%. And again, so people with personality disorders are often using substances, and whether that sends them to drug and alcohol treatment services or whether it sends them to mental health services I think is an interesting question. Sometimes I think there's a gender difference. So sometimes the males end up in alcohol and drug services and the females end up in borderline personality disorder treatment programs. We know in borderline personality disorder, the prevalence is actually 50-50. So there's half males with BPD and half females, but in treatment settings, more females show up or are retained in treatment. This is one of the kind of interesting questions that we have that we're thinking about. How do we change that? And of course, forensic settings vastly overrepresented by men. In terms of the other personality disorders, this is just a brief look at some of the others. So schizoid, antisocial, borderline, avoidant, obsessive compulsive. And in this particular study by Langas, 2012, it was around 46% for any personality disorder prevalence. We know that having the comorbid personality disorder and substance dependence is usually your more severe patients. So people with both tend to experience greater effects from the drugs, are more likely to engage in use for an earlier age, are more vulnerable to compulsive and rigid pattern of use, more likely to develop substance dependence, more vulnerable to relapse, and have more difficulty working cooperatively and collaboratively with service providers. Sound familiar? It's probably the reason why you're at this comorbidity webinar, because this is kind of the problem. We also know that impulsivity, which is actually one of the things that's actually hardest to treat and kind of like makes treatment a real challenge, is much more prevalent. And so there's a greater desire in people with personality disorder to have short-term rewards, to get rid of their big feelings, to feel differently about themselves, and to have a change in state. And whether that's using drugs, or whether it's self-harming or some other kind of strategy, this is the challenge that we often are faced with. Interestingly, not having it, patients without comorbid addiction are found to be 4 times more likely to experience remission within a period of 6 years. So there's a real challenge here. So not only is having the comorbidity of personality disorders and substance dependence highly prevalent, it's also likely to lead to worse outcomes and more difficult clinical challenges. Emotion dysregulation and impulsivity in many ways have been called the dark side of addiction. And there's a negative reinforcement cycles that come from when you're trying to withdraw, for example. There's also stress increases the risk and the compulsive use in times of extreme stress of impulsive strategies or a negative urgency. And in many ways, emotion dysregulation and impulsivity are also hallmarks of personality disorder. And so this is kind of the space that we're in. What we do know, though, about assessment of personality disorders is that these 2 key factors of problems in understanding yourself and problems in understanding others pretty much are the signature definitions of personality disorder that now is in the alternative version of DSM-5 and the new ICD-11. So personality disorders fundamentally emanate from disturbances in thinking about self and others. And of course, that is part of the problem that we're seeing in trying to work with people with substance dependence as well. If you want to read more about this whole development in terms of diagnosis of personality disorders, there's a short commentary that I wrote that tried to sort out all of those issues. We probably don't have time to speak about it now, but I'll show you some instruments that can be useful for you to use in clinical practice. Essentially, though, there's a growing consensus in the field that there's only one disorder, and that is personality disorder. And you just define it in terms of severity. So some moderate, severe, or extreme, that's in DSM-5 or in ICD-11, mild, moderate, or severe. And then you think about what are some of the traits of personality disorder that are important in the individual. So the emotionality or negative affectivity, the degree to which they're detached, the degree to which they're impulsive and disinhibited, the degree to which they're kind of antisocial and antagonistic, and the degree to which they're kind of rigidly perfectionistic. I think that's probably useful for us clinically, is to think about, does the person have a personality disorder in terms of those fundamentals of not knowing who they are and having a lot of difficulty getting the distance between them and other people right, in terms of severity, but then thinking about, well, how does that mostly look? Is it big emotions? Is it withdrawal from interpersonal relationships? Is it a sort of an antagonistic, antisocial kind of feature, or some other version? So, okay, so this is the first clinical tool I'd just like to introduce you to. This is a very simple, rough and ready way of saying, does the person I'm working with have a personality disorder? You simply give them this SAPAS. There are 8 questions, and they pretty much predict pretty closely whether or not the person has an underlying personality disorder. Answer yes if most of the time in most situations. Do you have difficulty making and keeping friends? Would you describe yourself as a loner? Do you trust other people? Do you lose your temper easily? Are you impulsive? Are you a worrier? Do you depend a lot on others? And are you a perfectionist? The cutoff score is 4 or more, and it's pretty good at being identifying whether or not the person that you're working with has underlying personality disorder. This is another study that we did just recently with youth at Triple Care Farm. Again, a lot of comorbid problems. In fact, we found that 56% met screening criteria for borderline personality disorder. So this is young people in a residential drug and alcohol. And we used the McLean screening instrument for borderline personality disorder, which is another very simple yes/no scale. So there are 10 questions. They basically ask the 10 criteria for BPD, like, have you had problems with impulsivity? Have you been distrustful of other people? Have you felt chronically empty? And so on. And here you can see the percentages of people who show up at Triple Care Farm who show these kinds of problems. The largest ones there are anger and self-harm. When we reflect upon all of this, and we often ask the question, you know, where do personality disorders come from? It kind of raises the whole question of chronic trauma, complex trauma, genetic inheritance, you know, where does all of this kind of fit together? This is our best kind of biopsychosocial model that basically says, consistent with the studies, and I've cited some of them here, it's really a combination of genes and environment. Actually, the genetic inheritance factor for personality dysfunction is about 50%. It's quite similar to a lot of other mental health disorders. So some people are just born more vulnerable to these, what we call AIR or AIR problems with affect, problems with identity, and problems with relationships. And it's a combination, and there's epigenetic processes that mean that, you know, depending on the environment and depending on your genes, it may express itself mostly as a genetic kind of personality dysfunction where your family life and your upbringing was good enough, or it might show more as a sort of a traumatized relationships and life events where there's lots of, you know, abuse or trauma or attachment disruptions and so forth that really fuel the underlying personality problems. And we know, of course, in terms of neurobiological models of addiction, that these things also play upon themselves over and over again in terms of the, I suppose, the cycle that really fuels the continual use. The question of which, you know, is it chicken or egg? Does the substance dependence contribute to the personality disorder, or the personality disorder contribute to the substance dependence? It has to be said that really the consensus now at the moment is that we just have underlying vulnerability to mental disorders, all of them, in one kind of dimension. And on scientific and clinical grounds, there is evidence that symptoms are continuous rather than categorical, and that the overlap between disorders is the rule rather than the exception. And that's the same here. All right, so that gives you a little bit of a sense of identifying personality disorders in the context of alcohol and drug challenges. And I've sort of talked to you a little bit about a simple way of doing that. How then do you respond? So I want to just give you a bit of a brief overview of some of the ways that we know that actually help and seem to be most effective. The first thing to make you aware of is there actually are NHMRC clinical practice guidelines. These are for borderline personality disorder, which essentially show or recommend that you really need to manage these things concurrently. So it's no good sending your patient with these disorders to two different therapists, one to look at the personality disorder and one to look at the substance dependence. We really need to treat the whole person. everybody is a combination of a whole lot of different things that are all interacting with each other. So we should have the same therapist. We should collaborate as much as possible. And firstly, the first priority is the stabilization of the substance use disorder if it's very severe and life-threatening and interfering with any capacity to actually benefit from psychological therapy. But there's no out. Sometimes people in drug and alcohol services have this fantasy: if the person has a personality disorder, we can send them somewhere else. And similarly, people in health say, oh, if there's a substance dependence problem in my patient, I can send them somewhere else. In many ways, we all have a responsibility to work in this whole comorbidity space. The good news is that dual treatments actually work. So if you treat both conditions and you think about both the personality disorder and the substance dependence co-occurring and working together and fueling, then it does well. Generally speaking, and this is a kind of an interesting one, and maybe we'll pick up this in the chat, just treating the substance dependence is less effective. Just treating the borderline personality disorders tends to actually improve both the borderline and the substance dependence. That's an interesting finding. And that kind of suggests that in many ways, you kind of need to go to treating the core of the person. And in some ways, if you do that, the substance dependence will look after itself. We know, of course, in psychotherapy, there's what's called the great psychotherapy debate, and that is that there's a big war between different brand names of therapy: DBT, CBT, transference focused, schema focused, mentalization based, and all of that. The general recommendation, and when you put these trials head to head, there's almost no difference in outcome. And it's these factors here: collaboration, empathy, alliance, affirmation, warmth, congruence. They're the things that actually make the biggest difference in terms of clinical outcomes. And the actual ingredients, or the brand name of the therapy, is a tiny, tiny effect in terms of outcome. So we often talk about, personality disorder is a disorder of relationships, and the treatment is relationships. So what people are coming to us for is to have a relationship that helps them to understand themselves, to understand their relationships, and to build a life worth living in the future, rather than just going back over all of the traumas and problems from the past. So what do we need to do? Okay, here's a quick kind of overview. Firstly, we need to just get some experience. And I first started off working in a prison. So I was working with a lot of people with antisocial personality disorder, but also a lot of people who actually came to prison because of their addiction and the crime and the associated problems or dealing. I then went and worked in drug and alcohol treatment services for some years. Then I worked in and currently still work in a personality disorder service, where, funnily enough, I actually end up seeing all of the patients that I've seen throughout all of those different types of services. Getting some experience really helps. Creating safety and structuring things. People come with a lot of chaos, and we need to offer them something that is contained and supportive and presents a different kind of frame than what they're used to. We need to be active in order to do that. You can't treat these disorders by sitting back in your chair and saying, tell me what's on your mind. If you do that, all you'll get is lots and lots of trauma stories, lots and lots of the things about that have gone wrong, and all of the kind of anecdotes about stuff that's going on for them that doesn't really help them, that might make them feel good to tell you those things. And what we call trauma dumping, that those kinds of things don't change the problem. Therapists actually need to say, well, we've got 50 minutes. We actually need to talk over the next 50 minutes about what's going on for you right now, and how can we help you to think about making the rest of today better, tomorrow, the next week, what are some of the things we can start to put in place that are going to anticipate and improve your current day-to-day functioning, and start there. We need to anticipate non-attendance. I always say to my trainees, 50% of the offered appointments won't be kept, and that's normal. We need to create an environment of curiosity where we're actually trying to hold the person in mind and trying to really understand what makes them tick. We may need to make sure that we really work on the engagement and the alliance, and help them and sit next to them as a collaborator in the project of helping them to understand their thoughts, feelings, and actions. That is the core of psychological therapy. That's what works, and that's what benefits people. That takes time, but it's even just modeling that, even in very brief and short-term interventions, can be very effective. And the final thing is you actually need to get support yourself. This is tough work. We see a lot of people with a lot of risky behaviors. We have to hold a lot of interpersonal tension. Sometimes we hear things that are very hard to hear. And we need to get our own support so that we can feel within ourselves strong enough to keep going, because burnout is a real risk. We start, of course, with an assessment. It doesn't need to be huge. I think there's some very short, well-validated instruments that can help you. But the most important reason to do assessment is to engage the client in treatment. And we say this about, diagnosis as well. A diagnosis is only useful if it leads to treatment. You can't just have a diagnostic process and then not have a follow-up. It needs to be one and the same thing, and it can actually be a very powerful step in the recovery journey. We have published on our website a brief intervention manual. We've published papers on it and done it in randomized trials and so forth. That's a 4-session, 1-month intervention. It can be quite useful for step down or step up approaches where you're moving people from acute services to longer term community care. It's there for you to use, and it focuses on, again, here and now problem solving, care planning. And I'm going to just talk about some of the key principles that are in this now. Firstly, that the first key principle is to be compassionate. It's difficult with people with co-occurring personality disorders and substance dependence. There's a lot of stigma. There's a lot of clinicians who don't like working with these people. And demonstrating empathy and demonstrating compassion, which doesn't mean you agree with everything the person's doing, but you can sort of make sense of it. And remembering that aspects have survival value given past experiences. These are the kinds of issues that really help us to hold the person in mind, to find something in them that you like and that you can connect with, and to therefore be on the journey with them as a really effective person who's on their side trying to help them. We also have on our website, this was developed in partnership with us, a modified DBD group therapy manual specifically for codependence of personality disorder and substance dependence. And it's quite useful. It's a dialectical behavior therapy. So there's a manual, there's a workbook for your clients to use, and there's also a website. So again, go to projectairstrategy.org and you'll find those as a download. All psychotherapies, irrespective of the brand name, are a balance of acceptance and change. And the first thing that we do when we're trying to engage a person in treatment is to use acceptance skills. So we try to help them to feel like they can be understood. We show compassion towards them. And we really try and spend a lot of time on connection before we move to a technology of change where we're trying to help them to do something different. So these ones come first. And we always say, you know, when a patient comes in very dysregulated, the first thing to do is to focus on the emotion before the cognition. And similarly, when you're starting treatment with somebody, focus on the support before you go to the hard parts of trying to help them change. And of course, these are the ones we want to see, you know, think and do things differently, healthier goals and relationships, and to encourage them to make the big decisions that are going to make a difference. But we can't do it until we have a really strong raft of support. So how do we do all of that? Well, I very much think that a lot of the effective ingredients are for the therapist to get the right balance. So on the one hand, the therapist is not like the analyst who sits back in the chair and just says, tell me what's on your mind. But similarly, the therapist is not the hard-nosed teacher who just tells the patient what to do. You kind of have to be in between that. You kind of have to sit on the edge of those two places. And we often talk about the curious stance or the not knowing stance as being your friend, where you gently and gradually start to ask them, what have you done in the past that's helped? When was the best time in your life that you really felt, you know, and what's different to that now, and what things have worked for you and what things that haven't worked, and start to use the person as the expert and you as the wondering student that's facilitating and encouraging them to find their own solutions and to start taking the steps of being active in their own recovery, rather than being passively sitting back and asking you to solve their problems. Because passivity, external locus of control, is associated with poor outcomes. And we've been doing a lot of research just in the last couple of years on those people who don't improve compared with those who do. We really think that activating agency and internal locus of control is one of the keys to clinical change. And really to help the person, therefore, develop a sense of the theory of mind of themselves and others, and have a greater capacity of them to be able to understand themselves in their relationships. I won't spend a lot of time on this slide, but I would just make a note to say that even if you're studying or using mentalization-based therapy, which is a psychodynamic treatment, or DBT, which is a cognitive behavioral treatment, the approach is the same. It's still using the curious, inquisitive, beginner's mind attitude and approach when you're sitting with the patient. So this is the care plan that Project AIR Strategy uses. It's on our website. You can download it and use it with your clients. We start at this point, we start by thinking about what do you actually want in the short term and in the long term. What's worked in the past and what hasn't worked? What are the things that trigger you and make you more at risk? And what are the things that you've done before that's helped you? And who's on your team? Who are the supportive people who actually you can call upon to support your change? And if you just identify those as a one-page care plan, it's not a big, extensive thing. And the patient holds one of those and you hold it and you can share it with others. That really holds and starts you off on the right journey. Triggers are very important. And of course, most people get worse at certain times and get triggered by things that really make it difficult. And they might cue substance dependence and problematic or other kinds of problems like self-harm. And so we really want to ask about triggers in our care planning process. And we also want to ask about things that they've done that haven't harmed them. So things that actually have kept them safe, going for a walk, leaving the situation, realizing that if they wait 10 minutes, the craves will go away. You know, lots of strategies that people use for ordinary self-care, having a hot shower, going for a run, picking up the phone and talking to somebody who, you know, is receptive and helpful. All of these kinds of ways are strategies we want to reinforce in the here and now, day to day, when you wake up, in the middle of the day, when you go to bed, ways of managing and reducing the impact of triggers. And thinking about all of these kinds of crisis survival strategies. There's lots of those around, and I'm sure you have all of your own favorites, and I won't mention those anymore. Recognizing, of course, that the invalidating environment is always there to trigger, and we need to think about that. And sometimes we also need to radically accept and realize that sometimes we can't change all of the negative things that have happened in a person's life, but we have to kind of like draw the line in the sand and say, okay, today we're actually going to be thinking about the future, not all of the bad things. And there's a part of us that needs to time bind all of that trauma and problems and say, we're not going to keep repeating those into the future. All right, so going back to our case study of Susie, you'll remember all of the problems that she had. We also need to start unpacking with her what are her relationship conflicts and how can we help her understand those repetitive triggers and how to recognize how she herself you know, sees that these triggers around attachment insecurities and the idea of threats of being, you know, that Tony's going to leave her as a case manager and so forth, that she recognizes them as triggers that make her feel more unsafe. And they are the kind of conversations that are going to really help. All right, so we're going to move now on to the final of our 3 points, and that is, how can you manage yourself? And I'll just share a few key lessons that we use and we've learnt, and then we'll open it up for general questions. The first is to recognize that we all are human and we all have our own reactions to this kind of work. What we often call countertransference, we feel often confused and uncertain about what we're doing. We can feel inadequate. I mean, the whole feeling of being a fraud, you know, that is very common in therapists. They're so sensitive and so concerned about their doing a good job that they often feel like they're not good enough, and it's only a matter of time before somebody's going to show them up to being inadequate. Holding that feeling, recognizing that you're not alone, that most good therapists hold those feelings and struggle with them. Obviously, there's a lot of problems in these sorts of settings where there's not enough time, that creating a safe space that where you and the patient can sit down and think about the issues in the here and now can be something you need to fight for and protect when there can be so many demands to do other things. And we also need to recognize that some of the clients we work with have done some pretty nasty things. So if they're perpetrators, that can be really tough. And similarly, if they're victims, that can be really tough. And they can pull us in different directions, either through rescue fantasies or punitive punishing responses where we actually think that this person doesn't deserve treatment. And of course, when suicidal risk shows up, that's when everybody gets anxious. So here's our solution. We talk about keep calm and make tea. And that is really the metaphor of when you make tea, you can't do it quickly. You've got to heat the pot. You've got to boil the kettle. You've got to pour it in. You've got to let the tea leaves seep. And by the time you pour it out and start to enjoy it, you're in a different psychological state. Now, some cultures, lots of cultures drink tea, and there's all sorts of rituals that go around tea making, I think for a reason, because it moves you from a reactive state to a reflective state. So that is the kind of metaphor that we use, that you need to hold as much as possible in the room, and that is to be reflective rather than reactive, and take time and give yourself time to develop some understanding before you have to feel like you have to rush in and do something. Just let yourself kind of like go, well, what's the problem we're really trying, and what is the real struggle here that the person has, and try and model that in the work. We know, of course, that, you know, when people are reactive, they use stigma words. So you probably heard these in both drug and alcohol and personality disorder settings, that people are just manipulating, attention seeking, non-compliant, uncooperative, you know, not ready, all that kind of thing. And we need to try and use language of respect and hope, like they're actually attention needing. They're choosing not to, that they're struggling and with vulnerabilities and insecurities, and try and transform our language around those clients to try and do that. And the best way of doing that is, of course, to share it with the team and have support. To recognize that we need to repair relationships. They sometimes are ruptured. We need to reflect upon those and try and again keep calm and make tea, and thinking about what's the best way of responding when there's been a rupture. We often have to be actively repairing those, and how you repair it actually is a powerful learning experience for your client. So that's it in a nutshell. They're the three main things that we wanted to go through today. Just to remind you that projectstrategy.org has lots of resources, and I look forward to the questions. There's my email. If you have things that you don't, or you think about them later, do get in touch, and happy to share what I've learned along the way, and looking forward to hearing how you've understood these things too. Thank you.
Thanks so much, Brin. You wouldn't have had the benefit of being able to see all of the comments that are coming up in the chats, but a lot of people saying how helpful they found it, you know, and very practical in terms of being able to implement this in practice. So thank you so much for that. We do have some questions, so I will kick off with those, and we'll get through as many as we can in the time that we've got remaining. One of the first one we had through was about clients who show pseudological fantastica with alcohol and other drug use, where you can potentially not be sure about what the truth is, that it's difficult to pick that out. Do you have any suggestions for working with clients displaying those symptoms?
Hold it lightly.
Mm-hmm.
Yeah, so I think about the reasons, like keep calm and make tea. Think of the reasons, what's going on for this person, and what's the struggle that they've got. And it might be that they're actually feeling really small inside, and or that the only way that they've got attention before is by having these dramatic kind of problems. Or so I think, rather than getting into some sort of battle around what's true and what's not true, just be neutral and be accepting, and try and connect as possible as well as you can with the person. And if you can do that, I think they'll eventually stop doing it. They'll stop having to use these kinds of issues, because the fear that they have that they're not interesting and that you can't relate to them in some way will kind of reduce.
And I think this sort of goes along with the lines of what you were saying about compassion and understanding previously. And I guess the importance of viewing it as something that this has been adaptive in the past, or, you know, but it may be maladaptive at the moment, but it has served a purpose for that person.
Yes.
And also one on trauma. Do you know what the rates of trauma exposure or experience are among clients with personality disorders?
Great question. It's a bit of a hot topic. Look, it's about 80 to 90%, but it really also depends on what you define as trauma, because I didn't really have a lot of time to talk about, you know, the genetic and environmental mix. But people who have a vulnerability to personality disorder are, we know, genetically more interpersonally hypersensitive. So they feel things more intensely. And we know from lived experience accounts, people talking to us about it, what was it like for them? You know, they say that there was nothing wrong with my parents, and I came from a happy family, but I just really struggled because I felt like the black sheep. You know, I saw my brothers and sisters being robust people who never worried about anything, but I worried about everything. And no matter what happened, I still felt like I was struggling. You know, that I think we need to understand that kind of experience, as well as the more obvious ones, which of course are, you know, where serious things have happened, like a parent's died, they've been incarcerated, there's been substance dependence or violence or other kinds of problems that are more obviously trauma-based.
Yeah, and I guess that it's coming back to that person's perception of what it was for them and their experience, as opposed to any sort of objective idea of whether that thing would be traumatic or not traumatic.
Well, it's important to remember that most people's reaction to trauma is normal functioning. So when a community is in something like a pandemic, for example, or, you know, earthquake or bushfires or floods, most people are resilient enough to get up on their feet and get back to, you know, normal functioning, even though they might need support along the way. What makes a trauma event for some people, though, so life-threatening and impeding, I think turns also around their vulnerability to feeling, you know, a lack of safety, and that feeling emotionally overwhelmed in ways that they can't manage.
Yep, that makes sense. And another question is around whether or not you have any suggestions around keeping clients on track and directing the focus and attention back to the treatment without coming across as being dismissive.
Well, I suppose this question, in terms of keeping clients on track, is where the client themselves wants to push you off track. Is that what I'm hearing?
Yes.
Pretty common. And look, clients come with a model of what you're trying to do with them. And I think it's important early on to explain to them how treatment works. Because I think a lot of people watch TV shows and read books and so forth, and they think that your role is just simply to be there to listen to all of their problems. And if they just speak them all out, they'll somehow vanish. What you need to do, though, I think, is say, look, this is a relationship between the two of us, and it's together that we can actually help you live a life worth living. And starting by defining the goals and then reminding them of the goals when things go off track is often a really helpful way of just resetting what you're actually doing, even though, you know, clients legitimately want to also talk about some of the bad things that happen to them or are happening to them. The key is, in a collaborative relationship, is how can the two of you turn that into something that can change the future, rather than just kind of do a forensic analysis of the past.
Yep. And what do you do when, there's another question around if a client is in significant denial about their own feelings or thoughts and having long-term suicidal ideation?
Well, obviously we need to keep calm because these clients make us very, very anxious. And of course, that's part of the interpersonal process, is that their passivity and their denial it still exists. But what's happening is it's being pushed into you so that you're the one that's holding all of the anxiety. And firstly, recognizing that's why you feel so anxious and why it's such a struggle. But then you can use words to then bring those feelings into the room. So you could say things like, look, I feel like there's a lot of underlying anxiety around these problems, or that there are things that I feel really terrified about that we're not talking about. And you start to use words yourself as a therapist to put into the room all of the unsaid things that the client is not, and try and build that bridge so that the two of you can start to look at them together. Because you're right, you know, when the client is withdrawn and suicidal and hard to reach, that's in some ways helping them to stop feeling all of those horrible feelings that you're feeling, but actually it's going to keep them in that bad state as well. So there needs to be somewhere where you can get those words out into the room.
Yeah, no, that makes sense. And I'm sorry, I have lots of questions myself as well, but I am just trying to go through these to get as many as we can answered for people because there's so much interest. But the Amanda has a question around the 4-session intervention that you mentioned. Can that be used in a group context, or is it designed solely for individual therapy?
It can be used in a group. We are doing a number of groups. One of the ones we're doing at the moment is actually a 6-week peer and clinician co-led group. Look, the basic principles are the same. The advantage of groups is that people leave saying, I didn't realize that I was, you know, that they feel less alone, and they feel much stronger and more compassionate towards themselves because they can also see that their problems can be shared. The disadvantage, of course, is you can't always, you know, individualize the kinds of issues. So in some ways, both work. There's not a lot of outcome difference between the two. Running groups can be a little challenging to get everyone there and to monitor that. But I recommend, I don't think we do enough groups in Australia. I think groups are a really great treatment way of working.
And I know our time is up, and then there have been lots of other questions which we will forward on to Brin, but also feel free to contact Brin directly, as he said, if you wanted to follow up on any of those. But just on that last point you made, Brin, I think one of the things that's really come through in your presentation as well is one of hope, where people often don't hear that in the case of personality disorders. They tend to hear more about this is hard, this is too hard, and it is hard. But, you know, I think those messages that you've given around treatment can and does work for people with these co-occurring conditions. And it's also, I think, a testament to the people who are treating as well, that do just an amazing job in both the substance use and the mental health fields as well. But thank you to everyone as well for coming along today. As Erin has put up previously in the chat, and we spoke about the slides and handouts, and the webinar itself will also be available for download online in the next couple of days, and we'll send you an email about that too. So thank you everyone for joining, and have a good afternoon. Thanks, Brin.
Stay safe, everyone.